第88回の医学教育セミナーを開催したいと、87回の医学教育セミナーを開催したいと思います。今回もスリニバ先生にお話しいただきます。ポスターですね。今日はちょっと司会あんまり喋らないんですが、ちょっと解説がいるので、医学教育、日本の卒業教育にはコアカリキュラムというのがあります。コアカリキュラムにのっとって、80大学すべてが教育をしています。したがって、卒業試験はもとより医者、研修に入る医者の実力はそこそこ同じであるということになっています。またそのコアカリキュラムにのっとって、実習前の CBT やオスキーが行われています。で、コアカリキュラムが最初に、設定されたのが2002年かな、10年ちょっと前です。それで改訂が2度3度行われていますが、特に前回平成22年度改訂の時には、国際認証も視野に入れて臨床実習を参加型パティシペタイプにするというのが大きな目標でした。で、そのために、ビデオも作り、それとかポートフォリオも作り、臨床実習の充実を狙ったものになっています。で、今回それから約5年が経って、コアカリを改定した方がいいだろうという意見があります。教育そのものをまず水平的統合、垂直的な統合、さらにアクティブラーニング、学生が自ら学ぶスタイルにするというような、日本の医学教育で一番弱いところですね。日本の医学教育は、オロジーというか、今までの解剖学、生理学、生化学というようなオロジーがあって、その壁が厚くて統合教育がされていません。臨床もそうです。内科もたくさんに分かれています。そういうのを統合しよう、垂直的に水平的に統合し、それから今までの医学教育は教え込む、教えてやるものなんですが、学生が自分から学ぶような教育を作るアクティブラーニングですね。さらに、昨日先生と話して気づいたんですが、卒業試験っていうと教えたものがここまでいってるかどうかを検査するみたいな、それが卒業試験だったんですが、新しい概念でいうと卒業生は自分の能力がアウトカムに達していることを証明しなければならないという主語が学生です。学生は教育のアウトカムを達していて、自分は卒業に値するということを学生が証明しなければいけないというような概念に変わってきています。それをどうやってカリキュラムに盛り込むか、そのあたりを今日は教えていただいて、一見カリキュラムのリフォーム、トランスフォームなんだけども、実は違います。これから10年の日本の医学教育の行く方向を見せてもらう、極めて壮大なシンポジウムじゃないか、セミナーです。これから10年先、どんなふうに動くかが分かると思います。そういうジャパニーズ。
Oh, no, it's okay.
You may understand.
A little bit,
Please.
So thank you everyone for coming today. Kitamura Sensei was so generous and he asked me to participate in the revision that he's leading for the core medical education model curriculum for 2016. And he'd asked if I could help with the translation of the last version into English. And based on that, he'd asked me to share a few thoughts and comments about the current 2011 model education curriculum. And I wanted to invite kind of a learner perspective into the whole thing. And so Kiyomi Morita Sensei is one of our emergency medicine / internal medicine residents. And we've been working together on a variety of projects. And she is a Todai graduate. So she's been kind enough to agree to share her thoughts on the curriculum and how real it is, whether it's actually being implemented or not, at least at this university. And we can talk about others too. And kind of use that as a moment to sort of accelerate change within Japanese medical education. So thank you very much, and thank you, Morita Sensei. So big hand to her. Thank you. She asked me not to put her picture up. I've got some really cute photos of her from her presentations. Can you hear me with or without this? Should I use this? Yes? Better? Okay. I think the volume may be turned down on this. So again, thanks to all of my wonderful collaborators and people who have given input, both from Japan and also the US. We have several learning objectives. The first is we're going to take a little bit of historical look at Japanese education and medical education. It's always helpful to kind of know where we've come from as we think about where we're going. We will look at the current core model curriculum that was last revised in 2011, and then take a kind of a brief meandering through a few trends in international medical education without getting too bogged down in the details, since it's much more of a big picture overview. And finally, kind of consider some options for where the model curriculum can go, and what actually can be done to improve or accelerate change within Japanese medical education. Does that sound okay? All right, that's great. So the first is kind of the idea of change. Right, we all change. Change is natural. It can be really quite wonderful as we kind of emerge from an earlier learner state all the way into, at least in medicine, a full-grown physician who can practice independently. And similarly, as we take our own personal paths, every field as it grows, develops and consolidates. It doesn't matter if the field is education in medicine, or if it is computer industries, or if it is the automotive industries, things that start off as very small individual shops, eventually consolidate, infrastructure develops, and then people globalize. So we see the same type of thing in medicine, and we'll kind of take a look at the historical perspective of where Japanese medical education started. And this is just a cartoon I like that reminds me that depending on where you are, you may want very different things. If you're on a desert island, any boat may look really attractive. Whereas if you're stranded on a boat, any small piece of land looks really, really good. Okay? So, back, as you guys know, back in the 1800s all the way to the 800s to the 1800s, Confucianist traditions and the Shinto traditions were really the educational traditions of the day. And the Confucianist tradition really valued education as one of the core duties of man. And it involved duty to self, duty to family, duty to society. And it was part of becoming self-fulfilled, of finding self-respect, and in many ways of having status in society. The indigenous Shinto traditions of medicine were often supplanted by the Kampo Chinese traditions, which blended with the local traditions in the practice of medicine. And really by the Tokugawa period, did I spell that right now? Yes. Okay, Morita Sensei was very kind to point out some spelling mistakes. So by the Tokugawa period, one of the things that had happened is that although the society had become a little bit more closed, as you know, they really did a lot to develop the infrastructure of Japan, improving roadways and allowing commerce to kind of go through the entire country. And at that time, too, one of the few outside influences that came in from a education perspective, at least for medicine, was the Rangaku traditions of the Dutch. So that was part of the evolution of medicine. As we kind of go a little bit forward, with the Meiji Restoration of 1868, as you all know, the doors of Japan were open to the world, And there was a very rapid modernization or westernization of Japan. In some ways that was really wonderful, in some ways that sort of left some of the great cultural traditions behind. And at that time too, a lot of other things happened. A Ministry of Education was formed, and Adinori Mori was the first minister of education. He had done a bunch of things, including coming up with some orders to be able to try to consolidate education and make it more freely available to everyone within the country. But his initial efforts didn't go very far, and I think after about a couple of years, only one of the 8 universities he wanted to start had actually been started. So they kind of rethought a lot of the centralization of control of education and tried to figure out how they could make education more accessible at all levels for people. And in the meantime, medical schools were beginning to be formed. In 1874, there was the first national exam of medical practitioners that became necessary then for licenses. And this was actually an attempt to be able to try to increase Western medicine. At the time, there were 23,000 Campo practitioners, but only about 5,200 people who were practicing Western medicine of any type. And in 1906, there was the first medical practitioners law that actually gave the Ministry of Education some teeth. They said that really no one could practice medicine until they completed a course at either one of the imperial palaces or one of the national universities that was Ministry of Education approved. They had to pass a licensing exam. And however, if you were a foreign graduate and had passed your own licensing exams, then you could practice in Japan as well. Right around that time, oh, this came out of order, a lot of new medical schools were being established. And as you know, as Japan was looking around the world for the most advanced medicine, at that time, it was really Germany that had held the best scientific traditions. And the scientific traditions of Germany heavily influenced the way Japanese medicine had formed, including the sort of one professor department that served Germany very well when they had a very low population of people. You know, they've all kind of been evolving and changing too over time. But the scientific tradition of the Germans and then the French really had a big influence in Japan. And Tanada-san wanted me to remind you that Juntendo University was actually the first medical school in all of Japan that was established during the Meiji period. So, moving forward to the 1910s. The 1900s were sort of, from what I've been reading, fairly interesting in Japan, as multiple things were happening. The economy was growing. There was a lot of, as people were, the country was becoming a little bit more militarized, and there were lots of vocational schools that were coming up. Elementary education was improving so that about 90% of kids were actually now in school, in comparison with 15% maybe just a couple decades ago. And it was a very, very big change as common people were getting educated on everything from reading and writing and well beyond using the abacus, right? Which had been sort of the standard at the time. And the Taisho era of the 1912s to 1936 was initially a great period of modernization, where a lot of the new educational ideas were coming in, including things like learner-centered education that we've been talking about. I don't know if you guys know the Montessori traditions, where sort of children are encouraged to explore. All of these started to really take hold until an economic downturn in Japan that sort of pushed some of the modern education ideas aside and sort of returned people to a more fundamental, basic way of education.
Excuse me,
Yes.
Taisho is 1926.
Do I have it wrong? Oh, thank you so much. I appreciate that. I have it, so that's one thing that you wouldn't have been able to catch. Thank you. Since this is all a little new for me as well. So thank you. In 1938, the Japanese Ministry of Health and Welfare was established. I believe it was just called the Ministry of Welfare initially. And that has a little implication soon. And then they established the first national medical care law, trying to put all medical practitioners under roof. It was really medical and dental at that time. And then had done a lot of renovations to it. I think I'm missing, oh, there we go. And with World War II coming up, there were several things that were happening in Japan from an educational standpoint. First is there were national textbook rules that had come in saying that only nationally approved textbooks could be given in schools. And so a part of the textbooks had removed at the time as Japan was becoming more nationalist, all mention of Western influences. And so I think the only three that were allowed were Edward Jenner, Galileo, and Beethoven. And by the time World War II hit, a lot of the textbooks had removed them as well. And this all changed, of course, post-World War II. But the militarization, there were actually soldiers who were going into middle schools and high schools to teach children basic drills and give them a military education. And at the same time, kind of helping them develop a sense of personal identity. This is all kind of background. In 1948, dentists, nurses, pharmacists, and physicians were all put under a different law, which is kind of the next version of the National Medical Care Law. And very importantly, they, in the act that this had, there's something called Article 1, which basically says that the Ministry of Welfare, now the Ministry of Health and Welfare, was the one who would grant medical licenses for duly qualified practitioners. And then by the 1970s, so during this time, in the post-World War II period, with the Allied forces sort of in Japan for a while, they had tried to have a more, they had changed the elementary and high school education system to be the, is it the 6, 3, 3, and 4, correct? 6 years of elementary school, 3 years of middle school, 3 years of high school, and then 4 years of college. They sort of implemented that sort of UK American system, and then had done two things for elementary education. One was to have the school board system of the United States, but then the French Central Authority system to be able to control and regulate school districts. So there was both increased local governance with more central control. So in the meantime, medicine was evolving very rapidly. As new technologies were coming out, and a lot of new medical schools had been built by the 1970s. And at that time, as Japan was looking around, realized that really needed to have a lot more medical schools to serve its growing population. And during that time period, 30 new medical schools were created. And really since then, Kitamura sensei was informing me that there haven't been any new medical schools recently built. So this was kind of a period of massive expansion. Also during this period, one of the things that happened was the medical societies became fairly strong as well. The Japan Medical Association, I think, was established in the 1910s or 1920s. It's fairly early on. And as medicine became more organized internationally, the same thing happened in Japan. The specialty societies became stronger. The deans and medical school associations also became stronger. So that kind of takes us to today. Did I miss any important milestones? You probably know the Japanese medical education system much better than I do. And I apologize for just sort of sharing all this. Is this okay? So the reason this is important is, past really helps us understand the future. And there's been a rapid evolution, as you know, in the educational system of Japan over the past 100 years. And it's been accelerating even more over the past decade or two. And let's kind of take a look about 20 years ago now. At that time in 1996, the Commission on Medical Education Renovation, jointly sponsored by the Ministries of Health and the Ministry of Education, had kind of looked at the Japanese medical education and had really asked, are we really where we need to be? Are there opportunities for growth? They had started comparing themselves again to other schools around the world and found some areas that they wanted to improve. And so had convened a committee together called the Coordination Council, and in 2001, with Fumimaro Takaku, am I saying that correctly? Takaku sensei, with his help and under his leadership, had created a report that said really four main things. First, we need to address humanism and personal qualities with the admissions process, not just based on standardized testing. The second is that it's important to limit the content of medical schools because there were just lists and lists of things that people were having to memorize. They wanted to deepen understanding and deepen engagement through active learning. And they wanted to be able to assess knowledge, skills, and attitudes in preclinical settings. Okay? So also not just in the clinical settings. Based on this, in 2003, the first medical education model core curriculum was developed. And the content, it was chaired, that group was chaired by Tatsuo Sato. And it had a lot of interesting things. The first, it had a lot of content that was very original to Japan, including things having to do with rural medicine. The second is it had a lot of objectives. It had 1,218 goals and objectives. Okay? So that's a lot of content to enumerate. About 2/3 of it was supposed to be core material and consume about, of the 6 years of medical school, consume about 2/3 of it, and 1/3 was supposed to be elective. The elective portion was supposed to be based on both what the students wanted and also what was unique to every individual school. So Todai is a great research university, would have a curriculum as part of their elective that would focus on research, or things that would really play to the school's strengths. And they also developed some general guidelines for clinical clerkships, although it was fairly thin at the time. Okay. So moving forward, in 2005, computer-based testing and OSCEs were put in place for the preclinical students. So by the time they ended, so it was in 1988 that the first national entrance examinations were generated, but they weren't really adopted by most of the medical schools until the 2000s, so it was about a 10-year lag period. So that was for admissions, and this was really to look for some core clinical skills for physical examination, history taking, and then the computerized testing, I think was about 200 or 300 items of fundamental knowledge about pathophysiology, etc. And in 2009, the first revision was created for the medical education curriculum. And it did a couple things. It looked at stage-appropriate acquisition of clinical competencies, really tried to work on learner motivation for patient-at-societal care, and reinforce the importance of research as part of the fundamental tradition of Japanese medical education, so that all physicians should be physician scientists. And that was a core belief. And they had defined, of course, the research really only having to do with basic science and with clinical research. And then in 2011, a second revision was created, which looked at core principles of physician education. That was a major addition, including fundamental attributes of a physician. Included things like professionalism and humanism, teamwork and communication, made a very, very strong push with Kitamura Sensei's help for participatory clerkships. In fact, he even produced videos as a resource, if anyone's interested in watching the videos. And also had recommended portfolios for assessment and started to develop the beginning of a toolkit for Japanese medical schools. So right now, Kitamura Sensei is leading the 2016 revision of this, and this is of course a very young and handsome Kitamura Sensei who looks quite serious. And in 2017, Japanese medical education, of course, continues to evolve, and there'll be specialty board exams starting, which is just, a year from now. So anyone who is a new graduate, Morita Sensei, you're going to have to take yet one more exam after your national licensing exam. Okay. So, any questions so far? Did I miss anything major? It's okay as a brief history? Okay, so let's take a look at the 2011 content, and what I'm going to do is I'm going to ask Morita Sensei to help me a little bit here. I'm going to talk about the development really quickly, and then we'll go into what it actually is, okay? So the first is when the Ministry of Education convened this group, they had had three groups. First was an expert study group in which major institutions received some grants to be able to study the process and outcomes of the current medical education curriculum to see if it was actually effective. The second was that they fed those results to an expert research committee that was composed of quite a few other people. It was not just educators and researchers, but it was also people who were in practice, people who were part of the public, dentists, pharmacists, researchers, nonprofit organizations. There was even a journalist as part of this group. So it was really leading thought leaders from Japan who had come together for this research committee, who then fed their recommendations forward to a coordination committee who had kind of taken a look at all of the work they had put together and came out with a final document. This went through an extensive vetting process with people representing the current chairs and presidents of the Japanese medical and dental associations, people who were the heads of departments and chairs of all the news organizations as well as the medical society organizations, hospital associations, people, senior officials from the Ministry of Education. And are you all familiar with this document, this model curriculum? So the purpose of the curriculum, again, was to provide a pathway forward for medical schools to be able to think about how they could share commonality and how they could create the best physicians of the day. Right? And so let's take a look at what this is like. It's playing, look at that, okay. And now, drum roll please, right? This is the current document. So this is a graphic of everything that's in the core curriculum. And it has, when I took a look at this, it just seemed like a lot. So since you guys know I like visual design, I sort of made it look a little bit cleaner, I think, so that we can go through it. Of course, now it's in English, so it may be a bit harder for the group to read. So hopefully it's a little bit more appealing visually. So if it's okay, what I'm going to do is, so let me just go over the parts of it. First, there's some core principles that we talked about. There's fundamental physician characteristics, fundamentals of patient care, issues with medicine and society, and this is really, so the idea was that when students would come into medical school, they would come in ready to learn medicine. And there were a whole bunch of prerequisites that they were supposed to take. And then going through years 1 through 4 of medical school, they would participate in life sciences and physiology, pathophysiology, principles of practice. They take their boards and then go into 2 years of core clerkships. And then, of course, for the residency, they would have 2 years of a rotating residency before they actually went into subspecialty training. And along the way, they would take electives. And the fundamental shifts were that there's now, fundamentals of patient care and medicine society are supposed to run through all 6 years of school. And these core values, these core principles, are supposed to be taught as part of the curriculum and both the formal and informal curriculum throughout all 6 years of school. So have you seen this before? People who anyone seen this before? Outside of Kitamura Sensei and Son Sensei? Oh, so not too many, okay. So this was the roadmap for all medical schools, and the adoption rate has been, has been medium, I think. Some schools are doing this well, some not as well, and of course you can see the CBT and OSCE between the 3rd and 4th year. Okay. So this was the aspiration and the goal of the committees, and this has been out for over a decade and a half now. So what I thought we could do is I'm going to go through each one of these, give you an example, and then I'm going to ask Morita Sensei to comment on whether or not it's actually being taught, okay? And or even more, whether or not it's actually being learned. And one thing that we're going to discuss a little bit about is the difference between, there's a scholar by the name of Hafferty, who in 1994 wrote a very nice article talking about what he called the hidden curriculum. Okay? So he said that there's really three ways we deliver curriculum. Okay? One way is something called the stated curriculum. This is kind of our vision statements and our mission statements and what's on our websites. Okay? So it's kind of what we intend to do. We may not do it. And then the second is the delivered curriculum. The delivered curriculum is the curriculum that we actually teach, so, or what people experience. So if part of the delivered curriculum might be we talk about, say, public health, and it's taught in a certain way, and or biochemistry, and we say we're going to teach biochemistry in a useful manner. It may or may not be that useful, but that's part of what we're actually doing. Much like kind of delivered patient care versus intended patient care, there can be a discrepancy. But the most important thing that determines learning is not the stated or the delivered curriculum. The most important thing is the hidden curriculum. It's the culture and values of the institution and how that's propagated, how people treat each other, what you actually observe people doing. You know I'm supposed to be professional, but if I'm always talking behind my hand about someone, or if I'm not treating people well or not communicating, it doesn't matter what I actually taught in class because it's not being practiced. Okay? So Morita Sensei is going to comment on, as we go through each of these, on whether or not it's being taught, and a little bit about sort of what the hidden curriculum is. And I can tell you, we talked earlier today, and having been to multiple universities now in Japan in several different areas, and talking to educators, her experience pretty much echoes all the other medical students and faculty that I've spoken to. So I hope this will resonate with you as well. And thank you for being so brave. Okay, so here are the 4 principles. It's graduating medical students must demonstrate mastery of 4 clinical skills. Medical students must demonstrate compassion and responsibility. Medical training must enhance research skills in fields related to health and healthcare, specifically basic and clinical sciences. And then medical training must be responsive to the current, and I put in emerging, needs of Japanese society. Are these being done?
So I think number 1, mastery of core clinical skills are not satisfied based on our education system, because we only have limited exposure to the patient or training. We have more observatory training. So.
And does anyone assess your clinical skills? I mean, you're not doing very much, but does anyone try to observe you when you're doing something?
There's a evaluation from the attendings, but it's a very strict evaluation.
Okay, and if you're not actually participating in care, there's very little for them to comment on.
But still, we can pass.
Okay.
We can still finish the
Sure.
rotation, even
Okay.
with any high evaluation.
Okay, okay. So even if you don't do particularly well, there's no consequence? Okay, all right. So no consequence for poor skills. How about this? Anything else that strikes you?
For number 3, our school provides actually there is opportunity for research training. We do have clinical research electives, basic research electives, and we also have extracurricular programs like MD scientist training program and clinical researchers training program. So I think compared with other universities in Japan, our school is one of the best universities to provide some kind of opportunities.
The research training here is very good. Great, okay. Do you think that that medical training has been changing with the times?
So about number 4, when I was in med school, there is no much opportunity at the clinic. But I heard that recently they send students to the other clinic other than the university hospital, so it might be more suitable for aging society of Japan.
Oh, good, good. So the next is sort of the idea of the fundamental physician characteristics, and it's value of life and dignity, patient-centered care, patient safety, teamwork, communication, and then on the next slide, of course, is comprehensive medical care, care for communities, research, and lifelong learning. So let me go back to the first one. What do you think?
So the value and patient-centered care, patient safety, we had some lectures dealing with that stuff, but it's just a lecture. It's kind of inconsistent. About communication and teamwork, we don't have so much opportunity to learn about them because most of the lectures are one way from the lecturer to the students, so we actually don't have plenty of opportunity to work as a team. We do have small lectures, small group session to discuss the controversial issues like organ donation or end-of-life care, but it's only limited time, of course. So
I see.
it's undertaught.
I see. And it's undertaught, and is it actually practiced well when you see it? You don't, okay. So you don't think it is? Okay. And you mentioned also teamwork. So how is teamwork being, do you see good teamwork on the wards or in clinics between services and between people?
So they somehow learn how to work as a team
Okay.
during their residency, but they're not prepared as a medical student.
I see. Okay. So there's some opportunities for improvement. How about this? Care for communities, lifelong learning. I know we talked about research already, comprehensive medical care.
So the comprehensive medical care might be undertaught because this is a university hospital, and the patients are, most of the patients are referred from the other hospital. They are already diagnosed, so we don't actually start from scratch. We do have the answers from the beginning, so it's I don't say it's a comprehensive.
Okay. So again, we're just listening for trends and modeling, and we're not criticizing anybody. We're just sort of describing the current state of things, which is important because all systems are in evolution, and Japan is committed to the best in medical education. So these are just opportunities for growth. And here, so the fundamentals of patient care, and so the fundamental physician characteristics was about 2 pages. Fundamentals of patient care was about 8 pages. Principles of patient care, patient safety, teamwork. Anything new that's popping up that you haven't mentioned? About patient safety, maybe?
So as a resident, we learn about patient safety, but for a med student, I don't think patient safety is taught well.
And then how about, so medicine and society includes things like epidemiology, lifestyle and disease, death and dying, death and the law, medical information management, which is a really big deal considering the massive amount of data we're getting, and behavior and environment. Any thoughts or comments on how well this is taught or sort of how well it's practiced?
So we do have some lectures for public health and statistics, but compared with the opportunity for basic research or clinical research training, these are undertaught.
I see. Okay, so it's undertaught, and again, not much opportunity for practice, right? Okay. So, so life sciences had 21 pages of the curriculum, and it went from organic chemistry to cellular biology, microbio, immunology, toxicology, and pathophysiology. And again, these were the first couple of years. And let me give you an example. So one of the things that the curriculum had done in the last revision is really articulate the goals of each subsection. So they might say low molecular weight substances in human physiology, explain the type and nature of amino acids, the type and nature of bases, nucleosides, and nucleotides, type and nature of monosaccharides, disaccharides, glycerol, and fatty acids. Okay, so this is directly from the stuff. So is this fairly well taught?
They are actually well taught.
Yeah.
We have, our school provides very thorough and detailed classes for basic research, basic medicine.
sciences. Okay, good. So good, life sciences looks like it's in good shape. And human physiology had 61 pages of the document. And it had quite a few things to it, nervous system, all of these systems. And let me give you an example of what they had done. So it was explained, so for lymphoma and myelomas, explained the classification, pathology, symptoms, diagnosis, treatment, and prognosis of malignant lymphomas. Explained the pathology, symptoms of the same thing, of multiple myeloma, although it seems that they weren't as interested, say, in classification. And then one really nice thing that the system had done was try to outline what was optional with kind of a separate star versus something that was much more, that was considered more core. So do you think that human physiology is fairly rigorously taught? It's about 61 pages.
Again, we have a wonderful program to teach human physiology.
Great, and I think that's pretty consistent. I think that the first two, categories C and D, uniformly through Japan, receive a lot of coverage. Okay. And how about physiology, human physiology? Let me just go further up. Okay, so this is another one for oropharynx. And what I want to draw your attention to here is that everything here is at the level of explain or describe. Okay, there's very little application. Are you familiar with a nomenclature or kind of a naming system by a guy called Bloom? Okay, so Bloom had come up with what's called the taxonomy, which is a way to name things. And he said that at the very basic, that had to do with human performance. And at the very basis of the performance is just of human performance is being able to memorize and recall things. And then, but things that are much more complicated, like synthesis and application and creation, are much higher on the performance scale. So what's being asked of all of the students in Japanese medical school is almost 100% just to memorize things and explain things. It's not synthesis, integration, application, or creation, which is really, from a physician standpoint, where we kind of want to get people to, right? We don't care if they know all the information. We want them to know the information, but they have to be able to use the information. So this is a pathophysiology and disease management. It had 11 pages. Okay? And an example, and this was basically all there was for chest pain. In contrast to the amino acids and covalent bonds that were described in detail with monosaccharides and disaccharides, chest pain explained the causes and pathophysiology of chest pain, explained the main diagnostic points of chest pain, outlined the initial treatment of patients with chest pain. So how well is this taught?
So in our school, all of the physiology lectures are based on the subspecialty, not like organ-based or symptom-based. So
Okay.
we don't have much opportunity for learning about differential diagnosis or clinical reasoning. So these disease management are undertone, I would say.
Okay. And then here we have stuff having to do with problem-based diagnoses for principles of practice. It's got a lot of problem-based symptoms attached to it. And this has also 16 pages worth of stuff. Some stuff on clinical management, and then a little bit on patient assessment and management. Is that well taught? I can't hear you.
So as I mentioned before, these are under because we only have limited opportunity. For example, like ER conference, they do review the clinical reasoning process, but in other subspecialty rotation, we don't have the opportunity to learn about the process for the clinical reasoning
Okay.
based on the symptoms.
And so this was kind of an example from palliative care. So what I want to point out is this, is that physiology got 61 pages. Clinical clerkships, and this entire thing has 10 pages, okay? And I'm going to, and this kind of goes from patient assessment to examination, core specialties. Only 6 of the specialties are called out specifically. I'm going to just show you, this is all of surgery, okay? So surgery basically says the entire clinical rotation is summed up with this. General goal, learn the diagnosis and treatment of basic surgical diseases. I wasn't sure if they also said something about responsibility for management. And the second goal was explain the risks and methods of surgical procedures and participate in preoperative and perioperative management. So covalent bonds and monosaccharides got much, much more space than the entire surgical clerkship. Okay. So we've already talked a little bit about the issues with clinical clerkships. And so the really big thing is this, is that there is a wonderful appendix that the core educational system put in called Appendix 3 that Kitamura-sensei worked on pretty extensively as well. That has great resources. There's accurate guidelines for how to do participatory clerkships, how to involve students, how to evaluate them. There's a portfolio system that got put in place. And it's really quite terrific. But again, no one's using it. Okay? So for the electives, about a third of the curriculum was supposed to be based on learners' interest in school specialties, and I know that's pretty variable. And so putting it all together, it kind of looks again like this. Okay? So the purpose of walking you through sort of where we were is to have a little bit of time. And any questions about this? Does this make sense to you now? Yes? Do you guys have any comments on this so far? No? Okay. I really think that the model curriculum gets an A for effort. Its heart's in the right place. It's putting out some very good ideas, and it has a lot of strengths with it. The fundamental physician characteristics, the core principles, the elaboration of things having to do with with everything from physiology to the clinical sciences is terrific, but it needs a lot of work, right? So the first problem is that it's got great content that very, very few people are using it. If they're using it, they're not using it very thoroughly, especially for the stuff that's beyond just things that are transmission perspective where one person's talking to a group, right? It's bogged down with all kinds of minutia. I mean, the fact that covalent bonds get so much play and that surgery or emergency medicine gets just literally a paragraph is really quite astounding. It needs a relook in terms of where the value system is. You just may as well say read an entire textbook of chemistry, which is basically just the table of contents, and as far as I could tell, nothing was left out. Okay? The content, again, is described at the recall level, not at the application level. As I'd mentioned, there's almost nothing on clinical clerkships. And there's the beginning of a resource toolkit that's being developed. And I think that that's going to expand over time very naturally. It's also missing a lot of things that are current in medicine, right? It's missing clinical decision-making, diagnostic reasoning, use of technology. There's a little bit on medical informatics, but that needs to be strengthened. Nothing on leadership, nothing on how to teach. And a big part of a doctor's job is to teach your patients and to teach your learners when you're in training. So there's there's more things too that we can talk about. So I just wanted to briefly take a meander at international medical education without spending too much time on it. Okay. So as you know, there's tons of organizations, including the World Federation for Medical Education, that have lots of ideas and lots of models for how education can be done in a learner-centered manner. And the big thing is this: like every other developed field, okay, medical education is now structured and it's organized, and it has many characteristics. It has infrastructure, it has evidence-based education, and it's gone from just describing content to looking at how people are performing. Okay? These are really, really big shifts. Okay? In North America, educational infrastructure is equal to research infrastructure. Okay? Medical education is recognized as a separate specialty. People get advanced training in it. I spent 3 years after my medicine residency doing health services research and medical education research. And participated in many faculty development programs. Every institution in North America and the UK has dedicated educators, much like our International Research Center for Medical Education, who basically spend most of their time doing med ed. We have facilities that are built for technology, that are flexible and allow for better assessment. Funding is still very tough all over the place because it's not a revenue generator, we're kind of a cost center. And our research and scholarship is improved, and there's lots of advanced training programs. So when we look at evidence-based education, this is really important. We know lots about how people learn. We pay attention now to developmental level. We actually do things having to do with active learning. We streamline content. We cut down on all the minutia, because most people don't need to know it. They need to know it's there. They need to know how to go look it up. But they don't need to have it there all the time. We're using technology better, and we're trying to involve learners in every aspect of their own education. Okay? And I'm just going to kind of quickly go over these things with content to outcomes, right? So you all know that there's lots of new content. I mentioned some of it earlier from implementation sciences, which is quality improvement and health services research, which is a big part of how we practice. How does medicine actually get delivered in society? How can we see if it's working? How can we make it better? When it's not working, how can we fix it? These are the things that implementation sciences asks, including behavioral outcomes. How can we influence behavior? Okay? So this is actually a large part of where research in medicine in North America is focused, on top of just basic advances for discovery. Okay? It's synthesis and application. We talk about how to teach and how to utilize systems of care. When you're in it, how do you navigate the system and make it better? We don't have very much education on financial management or how to be a leader or how to manage systems. People who are interested in those generally do a master's in business administration or master's in healthcare administration. And we try to figure out what to cut. One of the things that we cut is the private research of individual faculty who want to talk about why their thing is the next best thing. And it's because most of the students don't need to know it. And it's a big shift because you've got to get people away from wanting to just talk about themselves all the time. And we centralize control of the curriculum. Okay? And then we try to, again, do learner outcomes. And in North America, I'm sure, have people heard of competency-based education? Yes? Yes, a couple people, competency-based education. It's asking really the question, which is, not just what should we teach, but what should we assess? What's important about learner performance, about physician performance? Okay? And we've defined those. And when should they be able to reach each of those levels, which are called milestones, right? So performance outcomes are competencies, the general categories. Milestones have to do when people should reach those particular performance standards. And then, and how do you know, once you've defined those things, if you can actually trust them to do something? Okay? So you have to have good assessment methods, and that this actually is the focus in North America of a lot of the education movement now, because we've already developed, designated the competencies and the milestones, and we're trying to figure out the best assessment methods that don't overwhelm educators for when we can actually get people to do things on their own. And then finally, how do you house information and be able to share it in a way that generates feedback and positive results, as opposed to overwhelming people, again, with detail that's not really helpful. So having functional portfolios that are useful for multiple things. And then finally, we can assess all kinds of things fairly well with very good reliability and very good validity, okay, from knowledge, skills, habits, to teaching, including teaching of educators. And so what I want to sort of, this is the recommendations portion, but the idea here is that change is natural, okay? And a change can and change is a very good thing for us. And as we try to evolve Japan's medical education system, there's a lot of things that we can do. So as I was looking at the system and kind of considering the history of Japan, looking at the current medical education model curriculum, there's really three things that came to mind for how to be able to get people to use the great work that these committees have been doing, right? If you create something and no one uses it, it's a huge wasted effort. And there's almost no reason to go through the process except to sort of pat yourself on the back at the end of the process. And so things need teeth. So the first thing you can do is you can improve the model content. Okay? The second is you can try to improve evaluation of learners. And the third, which is a radical idea, is you can change licensure using Article 1. Okay. So to improve model content, there's tons of things that you can do. You can simplify the content, create goals for performance levels, do the milestone competencies and trustable professional activities thing. You can please make the core clerkship document much more useful, so people actually know what they should be doing and where they can improve, right? Provide better methods of evaluation and create and expand your toolkit, okay? So those are some just general recommendations, and really have the competencies done at the level of performance and not just of recall, right? Even when you're describing it. Okay? So the next thing you can do is you can improve evaluation, and this is important because we know that evaluation drives learning. And Morita-sensei, don't you think that if something is not well taught in school, but it's on the exam, will you learn it?
Yeah, because we have to be prepared for the exam, because we have to pass the exam.
Right.
So we just have to cram the knowledge just to pass the exam, even if we're not taught in the class or revision.
Yeah, absolutely, right? So if it's on an examination, the students will learn it, whether or not the school teaches it. So I'm not saying try to make it worse for the students by giving them more things to do, which is not the goal of education. You want it to be fun and enjoyable and participatory, right? But you can change a system so that you can actually make both students and schools evolve. And you can add national OSCEs to do what people have been saying that they want us to do, which is do things like have early clinical exposure, have clinical reasoning and diagnostic reasoning be part of what learners learn, okay? And I put in a few ideas here. You can have OSCEs for admission to choose people who actually have fairly good communication skills to begin with, or at least screen out the ones who are having a lot of difficulty and may have, again, as we talked about with the admissions lecture, maybe Asperger's or other conditions that make it very difficult to have good social interactions. Move the ones that are the current fourth-year OSCEs down to the second year. Okay? Teach people physical examination and interview skills very, very early on, and have enough of interviewing so that actually it's not just one station, which I think it currently is, but multiple stations, and ask them to do more, give them different types of challenges. So if you move it earlier in the year, or earlier in their training, then students will have to have early clinical exposure and learn these skills earlier. It will force the system to change. Okay? So the next thing you can do is you can have clerkships and OSCEs that teach some of the human, or that assess some of the human and behavioral medicine things that we think are important. You can have OSCEs on teamwork and on ethics and on professionalism and on communication skills. And you can assess these in very real life settings. You can do it in teamwork settings, you could do it with simulator labs, but you could do this in a way that allows learners to have their judgment and their prioritization and their professionalism all assessed in their communication skills. So, and it can be around important medical content that Japan feels is important. It could be around disaster relief and how to react in a disaster, right? You put that in before they get to the wards and expect them by the time they get to the wards, to their clinical experience, to be really, really, really prepared. And you can even ask basic things for clinical judgment. They should be able to take a basic history and make some basic decisions. Okay? If you test decision making for simple things before they get there at the level of a pre-clerkship student, and in North America that's pretty good, we can ask them to do very basic management stuff, then the system will evolve. Okay? And similarly, you make the ones at the end really much more appropriate to what you want a graduating physician to be able to do. Okay? As opposed to having just something in which they're doing an interview and taking a history, have them make decisions, have them actually show their clinical reasoning. You can do that both with the OSCE and with the note. And there's lots of great international models that you can use. The beauty of this is because the field of medical education is so well developed, you don't have to develop a lot of new things. You can just borrow other people's stuff and then evolve it for Japan. Right? It's a very great situation to be in because you can borrow heavily and everybody will be happy to contribute because they'll feel like they're part of something important. And the third one, to me, is the most important one. If this committee, if this group can do one thing that would really change fundamentally the nature of Japanese medical education, is to change the pathway to licensure. Okay? And what I'm talking about is taking a really, really, really big leap. And this is a big leap of institutional accreditation and using Article 1. Okay? So institutional accreditation means that basically you make this institution qualify before their learners can actually sit for an exam. Okay? If you make the institutions pre-qualify, and you can do it based on performance standards of their learners that they have to document and demonstrate and give to the ministry. Or if you do it based on the infrastructure of the organization that they have to have before they can actually let their learners sit for an exam, they will change, okay? Because they will have to change. The reason in North America we've been able to get changes made is not because our educators are so enlightened, or our deans are so enlightened, or the hospital is happy to part with so much money. It's because we have levers of accreditation and licensure that are forcing change. Okay? It's not done out of the goodness of everybody's heart, although we would like to think it is. Now that we're doing it, we say, oh, look at us, aren't we great? But the way it happened is because the Accreditation Council for Graduate Medical Education in the US, the Canadian Medical Association, the Licensing Committee for Medical Education, the Osteopathic Associations, all of which accredit schools and then make it possible or impossible for you to get a residency program and then get a job, so that if you don't do these things, we won't accredit you. Your people can go through the program and graduate, but they can't get a job afterwards. They won't be able to sit for their licensing exam. Okay? So the entire thing about controlling equality through licensure can be done on lots of levels. And I think thinking creatively about what we can do is really important, okay? So you can say that before learners sit for a licensure exam, institutions have to demonstrate that learners have appropriate clinical skills, okay? This is a big idea because you can have them demonstrate clinical skills for, it'll force a system to have sound evaluation system. They'll have to train their faculty. You'll have active learning. You can mandate participatory clerkships. You can even test for things, and you can have them demonstrate that learners can do things like have participated in a quality improvement project, demonstrated professionalism, demonstrated leadership. If the school needs to document that, say, 90% of their students have met these criteria, then the system will evolve. Okay. Similarly, and one of the things, of course, is then you have to check that it's done properly. Much as many of the faculty here have been doing site visits, you can do site visits with teeth, not just site visits for the sort of sake of doing site visits. Okay. And you can also ask that institutions have adequate infrastructure. And the infrastructure can be time to teach and craft a curriculum, adequate time for the faculty, central control over the curriculum, adequate staffing, adequate technology, adequate staffing. And these can all be defined by Japan in whatever way Japan thinks is appropriate. Okay? And so, you know, the Ministry of Health and the Ministry of Education, if they were to collaborate on this process, there would have to be a few things, probably a little bit of funding. There'd have to be training made available to educators around Japan to be able to implement these recommendations. You'd have to find ways of helping institutions support them to kind of develop the infrastructure they need. It may be expensive, there may be ways of sharing costs. And then you also need to think about a pathway for institutions who don't meet the appropriate standards. What do you actually do with them? We never want to penalize the learner, and we certainly want to motivate the learner to learn well. But we don't want to sort of reward institutions that aren't responding appropriately. Okay. So going back to the idea of change, you know, I think change really is possible in any direction you want with the right lever. And I think change is both very natural, and when it's done well, it's often quite beautiful. So those are some of my thoughts, and I wanted to thank Morita Sensei for sharing hers too, and all of you for coming today.